Hi, hello everyone. Welcome to Dr. Ravichandra official. In the last episode or the last video, we have discussed cell injury, causes of cell injury, what is reversible injury and what is irreversible cell injury. In a nutshell, there will be few changes that will be seen in a reversible injury, and the reversible injury will be when the injurious stimulus has been removed, the cell will revert back to normal, and these changes are temporary. Whereas in irreversible cell injury, the cell has been exposed to a stimulus which is lethal to the cell. Thereby, there will be a changes in the cell which are irreversible, and these irreversible cell injury changes will finally lead to cell death. Examples of irreversible cell injury are necrosis and apoptosis. In the reversible cell injury, there will be swelling of the endoplasmic reticulum, swelling of the mitochondria, there will be cellular blebs formation, okay, and whereas in irreversible cell injury there will be swelling of endoplasmic reticulum, and because of that there will be loss of the ribosomes, there will be membrane bleb formations, swelling of mitochondria will be there, lysosomal rupture will be happening, there will be nuclear condensation also, and finally the fragmentation of the cell membrane and nucleus. So coming to our new topic, necrosis. It is a type of irreversible cell injury. Before going into the topic, I like to request please like, share, and subscribe Dr. Ravichandra official. Now, what is necrosis? Necrosis refers to a spectrum of morphological changes that follow cell death in living tissue, and they are because of the result from progressive degradation action of the enzymes on the lethally injured cells. So, necrosis is because of the progressive degradative action of the enzymes on the lethally injured cells, which will finally lead to cell death. In the Viva, they will be asking whether there is a inflammation in necrosis or not. Definitely, inflammation will be there. Then, why inflammation around a necrotic cell? This is another Viva question. Necrotic cells are unable to maintain the membrane integrity and their contents often leak out. This will elicit inflammation in the surrounding tissue. Now, coming to pathogenesis of necrosis. Necrosis occurs because of the autolysis. Autolysis is due to enzymatic digestion of the cell and the denaturation of the intracellular proteins. Enzymes are released from the lysosome of the dead cells themselves or from the immigrant leukocytes of inflammation. There will be cytoplasmic changes and nuclear changes in a necrotized cell. First, we will discuss the cytomorphological changes or cytoplasmic changes. There will be increased eosinophilia attributable to loss of the normal basophilia imparted by RNA in the cytoplasm. And there will be more glossy, homogeneous appearance, characteristic feature of a necrotizing cell. There will be cytoplasmic vacuolations due to digestion of the cytoplasmic organelles, and the characteristic appearance is called as moth-eaten appearance. So you may get MCQ question. Moth-eaten appearance is seen in option A reversible injury, option B necrosis, option C both, option D none. Your answer is moth-eaten appearance because of the cytoplasmic vacuolation is seen in necrosis. So this is a picture showing a myocardium. In the first part, it is the normal myocardium, and in the second part, it is the myocardium because of the lack of oxygen supply, ischemic myocardium, which will result in necrosis. Another cytoplasmic change in a necrosis is the dead cells are replaced by large, whole phospholipid masses called as myelin figures. There will be calcification. Phospholipids are degraded into fatty acids which undergo calcification to yield calcium soaps. On electron microscopy, you will be able to appreciate discontinuous plasma membrane. There will be dilatation of the mitochondria with appearance of the large amorphous densities. There will be intracytoplasmic myelin figures and amorphous osmophilic debris. There will be aggregates of fluffy material because of the denatured protein. In this picture, you can observe a necrosed or necrotic cell or necrotic cell. In the electron microscopy, under the electron microscopy, there will be swollen mitochondria. At places, there will be cytoplasmic vacuolations. In this picture, you will be also be able to appreciate dense pycnotic nucleus. So, cytoplasmic features, you will be able to appreciate increased eosinophilia, cytoplasmic vacuolations, calcifications, and myelin figures. Now coming to nuclear changes. Three forms. First one is karyolysis. Second one is pycnosis. Third one is karyorexis. Karyo means nucleus. Remember, karyolysis. Basophilia of the chromatin may fade because of the increased DNase activity. Pycnosis, that is shrinkage of the nucleus and increased basophilia. The DNA is condensed to solid basophilic mass. Karyorexis. Rexis means fragmentation. Karyo means nucleus. So, after the formation of pycnotic nucleus, this pycnotic nucleus, there will be fragmentation. So, fragmentation of the pycnotic nucleus is karyorexis. So, three nuclear changes will be seen in necrosis: karyolysis, pycnosis, karyorexis. Now we will discuss types of necrosis. Mainly, the necrosis is of four types. One is coagulative necrosis, another is liquefactive necrosis, third one is gaseous necrosis, fourth one is fat necrosis. Along with this, few books are giving two more entities, that is fibrinoid necrosis and gangrenous necrosis. First, we will discuss coagulative necrosis. Coagulative necrosis is because of the denaturation of the intracellular proteins. Coagulative, coagulation of the proteins. It implies preservation of basic outline of the coagulated cell at least for some days. This is a important microscopic finding. The organ undergoes coagulative necrosis will have firm texture. Examples: myocardial infarction, acidophilic coagulated anucleated cells persisting for few weeks. Ultimately, it is removed by phagocytosis by our scavenger leukocytes. So this is a beautiful picture of the myocardium showing a extensive coagulative necrosis because of the denaturation of the intracellular proteins. This is a gross picture of a kidney showing a wedge-shaped coagulative necrosis. This is a picture of the gross picture of a spleen showing coagulative necrosis. And this is a microscopic picture of kidney showing coagulative necrosis. If you observe, because of the denaturation of the intracellular proteins, when compared to the surrounding areas, there is cellular outlines are seen because of the coagulation of protein. This is one more picture of adrenal cortex infarction causing the coagulative necrosis. If you observe, there will be clear distinction between a necrotic cells and a normal cellular area. Because of the pyknosis, karyolysis, and karyorrhexis in the nucleus, and increased eosinophilia, cytoplasmic vacuolations, myelin figures, and calcification in the cytoplasm. Liquefactive necrosis. It is the most common hypoxic death in central nervous system. So it is the most common cause of hypoxic death in central nervous system. So, and it is caused by enzymatic degradation of tissue. Coagulative necrosis is because of the denaturation of intracellular proteins, and liquefactive necrosis is because of the enzymatic degradation of the tissue. As a result, there will be transformation of the tissue into a liquid viscous mass. It is seen in fungal and bacterial infections. There will be formation of pus, which is cream yellow material containing dead white cells. This is a picture of a brain. Clearly, you can appreciate the liquefactive necrosis in right side of the picture. Shown by arrow. This is the one more picture of brain showing liquefactive necrosis because of the enzymatic degradation. This is a microscopic picture of the brain showing liquefactive necrosis. This is one more picture showing necrosis. This is a picture of liquefactive necrosis in kidney. Now coming to caseous necrosis. Caseous, the name itself is saying cheesy. It is most often seen in tuberculosis. So tuberculosis of lung, tuberculosis of intestines, tuberculosis of lymph nodes, everything. Wherever tuberculosis is there, You can simply write caseous necrosis. Here you have to remember one important point. Coagulative necrosis is because of coagulation of intracellular proteins or denaturation of intracellular proteins. And liquefactive necrosis is because of enzymatic degradation of the tissues. Now coming to caseous necrosis, it is because of both enzymatic degradation of the tissues and also denaturation of the cellular proteins. There will be formation of a cheesy white gross appearance seen in the areas of necrosis. And this cheesy white is because of amorphous granular debris enclosed within a distinctive inflammatory border. So, this is a example of granulomatous inflammation. This is a classical picture of a lung showing caseous necrosis, cheesy material you can appreciate. This is one more picture of a lung showing extensive caseous necrosis. This is the microscopic picture of caseous necrosis showing the few giant cells are there and there is central eosinophilic material surrounded by epithelioid cells and few inflammatory cells. Now coming to fat necrosis. The name itself is saying fat, so it is mostly seen in adipose tissues. It is due to release of the activated pancreatic lipases in a pancreas and also in peritoneal cavity, destroying the fat. Most common cause of fat necrosis is seen in acute pancreatitis. The enzyme lipases will split triglycerides into fatty acids, which will combine with calcium to produce grossly visible chalky white areas because of the fat saponification. So, if a organ with chalky white areas on gross examination is given, you can simply write fat necrosis. So this is a picture, both gross and microscopy of fat necrosis. You can be able to see chalky deposits, seen white chalky deposits. This is because of the fat saponification. Actually, this fat necrosis can be because of the trauma or because of the enzymes. The traumatic fat necrosis is seen in breast and buttocks following a blunt trauma. And enzymatic fat necrosis is seen in acute pancreatitis because of the release of the pancreatic lipase, which will liquefy the fat cellular membranes. And along with this, because of the conversion into fatty acids, which will combine with calcium, resulting in fatty chalky white deposits, visible chalky white deposits called as fat saponification. Microscopy. Foci of necrotic fat cells surrounded by basophilic calcium deposits and also inflammatory reaction. Finally, it may end in dystrophic calcification. So, you can get a MCQ like this. Saponification and dystrophic calcification is seen in caseous necrosis, coagulative necrosis, fat necrosis, all the above. The answer is fat necrosis. So, along with the coagulative, liquefactive, caseous, and fat necrosis, for completion's sake, I am telling fibrinoid necrosis. In the last class, we have discussed that Whenever we use suffix oid, it means like. So fibrinoid, fibrin-like necrosis. So it occurs in the walls of the blood vessels secondary to the injury, leading to insudation and accumulation of the plasma proteins, giving an eosinophilic hue. Example of a fibrinoid necrosis is, so fibrinoid necrosis means it will be seen in blood vessels. So fibrinoid necrosis of the blood vessels in both immune and non-immune vasculitis. Vasculitis is itis suffix means inflammation. So inflammation of the blood vessels. Immune and non-immune vasculitis are examples of fibrinoid necrosis. So this is a picture of gross and microscopy picture showing fibrinoid necrosis. You can appreciate the fibrin-like material in the picture. Now coming to gangrenous necrosis. So this is not a separate entity. It is a coagulative necrosis of the tissue. Along with the coagulative necrosis, there will be super added putrefaction caused by putrefactive bacteria like Clostridium species. So gangrenous necrosis is one type of coagulative necrosis. Grossly, the organ is grayish black in color and it will be foul smelling. Gangrene can be dry gangrene and wet gangrene. Dry gangrene is seen in where there is dry regions. Okay. Wet gangrene is seen in wet regions. So dry gangrene example is fingers, wet gangrene intestines. So this is a picture showing dry gangrene or necrosis of the body parts. The toes were involved in a frostbite injury, and this is an example of dry gangrene, and it is due to coagulative necrosis from the anoxic injury caused by frostbite. There will be a clear line of demarcation in dry gangrene, whereas in wet gangrene, you will not be able to appreciate a clear line of demarcation between a viable tissue and non-viable tissue or dead tissue. Wet gangrene. This is a gangrene of the lower extremity. Earlier I have said it is seen in wet tissues. Sometimes it is observed in lower extremities also. It is more applicable because of the liquefactive component from superimposed infection. So gangrene is, as I said, it is a type of necrosis along with superadded putrefactive bacteria. So it is liquefactive component from the superimposed infection in addition to the coagulative necrosis because of the anoxic blood supply or loss of blood supply. This patient is a suffering from diabetes mellitus since many days. So in the exam you will get a bit like this. Dry gangrene is seen in, okay, or wet gangrene is seen in diabetes mellitus. Which type of gangrene is seen? Option A, dry gangrene. Option B, wet gangrene. Option C, both. Option D, none. You have to mark. If it is a diabetes mellitus case, there will be coagulative necrosis and liquefactive necrosis. So there will be dry gangrene and wet gangrene also. Dry gangrene because of the coagulative necrosis from the loss of blood supply, whereas the liquefactive part necrosis is causing wet gangrene because of the liquefactive component from the superimposed infection.